Welcome to the NEI podcast. This is Dr. Sabrina Siegel with the Neuroscience Education Institute, and I am interviewing today the Chief Medical Officer at the American Foundation for Suicide Prevention, Dr. Christine Moutier.
Hi there.
Dr. Moutier, would you be able to share with us a little bit of background with what resources someone can find at the AFSP website?
Absolutely. Anyone who is interested in learning more about suicide risk assessment, the care of patients, and also what you, as a general citizen, a family member, a community member, can do in terms of preventing suicide and how to teach the public about preventing suicide. We have chapters in all 50 states. We have Out of the Darkness walks that anyone whose life has been touched by suicide, whether it's through a personal loss or your own personal struggle, or if you are a clinician and you just care about the cause, or you have lost a patient to suicide, all sorts of people, policymakers and researchers, are coming out for these Out of the Darkness walks and other awareness raising events. And so you can find all of that on our website at afsp.org.
Now, why do you think that there's such a social stigma around the topic of suicide? And do you feel like that's changing? And if so, why?
Well, if you think about any topic in our society that has carried a lot of stigma, that can change when science provides answers and sheds light on the true drivers of that issue, and if there is prevention and it's possible, which science is doing all of that related to suicide. We understand more about it now. And then translation of those research findings into education and awareness raising so that the public can have a sense, just like they do for what drives heart disease, and people have a general understanding of cancer and HIV/AIDS now. That took the stigma out of all of those issues. And so the same thing is now happening for suicide as the science has been growing and then translating that and disseminating that information to the public.
It's great that science is really what might be at the heart of this sort of, dismantling the stigma of mental health altogether. What would you say are some of the warning signs that someone could be suicidal? You probably get asked this question a lot.
Yeah, no, but it's actually a really important question because we should know the classic warning signs, most definitely. Any sign of change in behavior patterns, withdrawing, seeming less engaged in their life. And of course, all of those can be just signs of depression. But if an individual seems like, in addition to that, they're feeling particularly hopeless, trapped, or like they're a burden, certainly if they start talking about having suicidal thoughts or even that they'd be better off dead, um, they don't always give you all of this right there on a platter using those words, though. So you really have to trust your gut instinct and follow those clues that, for example, if someone is feeling like a burden, it may come through in the way that they're behaving and the way that they're talking about things. But some other more clear indicators to be on the lookout for are other changes like increases in substance use or drinking, starting to give their belongings away, and sort of any sort of communication that's uncharacteristic where they seem like they're out of the blue sort of saying goodbye. Those are all signs to really pay attention to.
What you touched on is important because the messages might not be very clear, but if you're listening well and you're paying attention, you would be able to see those signs, and then we would be able to do something. That leads me to my next question, which is, if you detect warning signs, what should you do in that case? And do you think you could share with us some of the do's and don'ts once you've identified warning signs in someone?
Absolutely. I think the main and most important one that I've been guilty of in the past as well is just avoiding the situation and rationalizing it, and leading yourself to believe, what, they're just under a lot of stress. I don't need to do anything. And I think that's the biggest problem that we've had in our society. We became very sort of overly emphasizing and knowledgeable about stress and its impact, which is all very real. But that doesn't take away from the fact that people can become at risk for suicide. And whether it is the stress that's contributing, of course, stress always contributes to our mental health. And for people who have a special risk
Yeah.
of suicide, stress absolutely contributes, but it's not a reason to write it off and to ignore it. So that would be the first thing that I would say is just um, remind yourself that you might be the only one who's noticing, and you may be the only one who is in a position to reach out to them. And then the next thing is really to set up a caring, private conversation where you can allow them to share what's going on. So it really requires a lot of active listening skills, something that we don't necessarily practice in our everyday lives enough. And really express to them the things that are in your head that you think you don't need to say, perhaps, like, I'm not here to judge you. I'm only here to support you and to make sure that you get the support that you need. I'm going to help you with that. So, the key thing is to actually assume that you might be the only one who's in a position to reach out, and do reach out to them and set up a time to speak with them in private. Be very direct and let them know that you're concerned because you've noticed, and just tell them in a straightforward way, but be sure to explain that you're there to support them purely and not to judge them. You want to help them and you want to understand what they're experiencing. So it's not just the casual, hey, how's it going? It's a much more intentional, I really want to understand what you're going through right now because you don't seem like yourself. And then it's really a matter of practicing active listening skills and allowing the person to talk, follow their cues. You know, some things to avoid as well are to avoid jumping in with quick fixes and solutions, which is really hard for all of us to kind of just open up our ears and close our mouths for a longer period of time while so that they will talk more. That is helpful for them to share. And you can ask them directly if you have any reason to
Mhm.
believe that they might be having thoughts of suicide. Ask them, say, the things that you're talking about sound really difficult, really stressful. Sometimes when people are experiencing those things, they have thoughts of ending their life. Is that happening for you? And just like that, and let them answer the question. And if they are, then that's a time to help them with resources. And so, knowing the National Suicide Prevention Lifeline, which is available 24/7, that's 1-800-273-TALK, and the crisis text line. If somebody feels more comfortable texting with a trained counselor, that's another excellent resource, also available 24
Right.
7. And it doesn't have to be the person who's in distress, it can be the helping person who reaches out to those resources for help if you determine that the person is having thoughts of suicide and you're not sure if it's truly dangerous and you need to take them to an emergency department, or if it can just continue with the conversation, and just a caring, sort of friend approach.
Right. Wow, that's really good to know. We've seen that there's been a reported rise in suicide in the last 20 years. What are some of the reasons that you think this might be happening?
Yeah, that is a really challenging issue for us. We are in a national state of a public health crisis with our issue of suicide. The truth is that that has been the case for many, many decades. As far as we go back to the death investigation system and the CDC recording suicide deaths, back into the 1800s, there has always been a base rate, and it has fluctuated over the decades. And over the last couple of decades, there has been about a 1 to 2% increase per year, totaling a 28% increase overall in our national rate of suicide since 1999. And because suicide is always a multifactorial health outcome, there's not going to be just one thing that we're going to be able to talk about. It's going to be about the culture around help
Mhm.
seeking, the sophistication by which we understand mental health and can support each other. Other things, though, that are more outside the healthcare space include changes in the economy, whether the culture actually is supporting natural opportunities to connect with each other as community members. Those are all factors that can impact suicide rates of a population.
Right, right. Now, we've been talking a little bit about just how science can help us learn a lot more about suicide prevention. And, for those of you who are listening, if you go to the AFSP website, you can just see, pretty much hundreds of scientific studies that are going on right now currently. And I believe that the AFSP is the largest provider for private funding for suicide prevention research. What can you say? I know that it's listed on the website, the top 10 research findings from what we know from a scientific standpoint at this point. Would you be able to share a few of those findings with our listeners today?
Absolutely. And what you said is mostly true. AFSP is the leading private funder of all suicide and suicide prevention research. So, of course, the National Institutes of Mental Health also fund, but we need more of a national level investment in suicide research in order to drive down the rates. So, the overall investment so far is still far too small. So, the field of science around suicide and suicide prevention has really been burgeoning over the last decade or two, so much so that some of the key findings about risk factors and protective factors are really getting solidified. And now we're into new areas around prediction analytics and using big data, as well as all of the multiple disciplines that are coming together to study suicide. So I'll share some of the top findings, and these are all available on the AFSP website. If you just look up AFSP suicide prevention research, you'll find a whole lot of studies as well as our top 10 sheet. So one of the key findings is that people who die by suicide don't have that final act of taking their life for one reason. That is never the case. It's always multiple risk factors that pile up. And one key risk factor, obviously, are changes in mental health and mental health conditions. But those aren't the only factor. There are other risk factors that contribute, including even childhood trauma, substance use, chronic physical problems, including chronic pain, and cultural factors, many other factors, the economy, things like that. But one additional finding from this literature that is called the psychological autopsy, sort of niched area of suicide prevention research, relates to the most sort of predominant, you could almost view mental health conditions as a necessary but insufficient risk factor for suicide. And that finding is something you hear a lot. It's kind of a synthesis of many, many psychological autopsy case studies. And that is the finding that approximately, and usually in most cases, more than 90% of people who die by suicide in these psychological case studies have an underlying and potentially treatable mental health condition, but that does not mean it was identified while they were alive. And so that's where some of the confusion comes in terms of the contribution of mental health conditions as they relate to suicide risk.
Right.
Another key finding is that if you limit access to lethal means, not just for an individual at a time at risk, that is certainly a strategy that clinically we should be using, is counseling on lethal means, particularly when suicide risk is increasing. But the evidence for doing that not only comes from that particular strategy of counseling on lethal means, but it comes from the larger literature of naturalistic findings in the world where things like things changed, like, for example, in the UK, coal gas used to be their main source of energy. When that began to change in the 1950s and 60s to other forms of energy, coal gas had been one of the primary means of suicide in the UK. And so their population in the UK rate of suicide went down by 40% just because that coal gas method was no longer available. Multiple studies of other modalities like building bridge barriers, changing shut-off valves on automobiles for carbon monoxide, firearms policies that changed in the Israeli Defense Forces, all show that same finding of about a 40% decrease in the overall rate of suicide, not just by that method. And that really speaks to another conclusion that we can make, which is that people don't usually switch methods. And so this notion that people who are, quote, at risk for suicide are bent on suicide, that is not a correct way to think about suicide risk. It's very dynamic. The period of acute risk tends to be short. That's another finding in the suicide literature. It's a little bit complicated by the fact that people can have thoughts of suicide recur or be chronic, but the moment of acute risk tends to be very short, where the brain changes, where there's cognitive constriction, and where the person is able to break through those usual coping mechanisms and survival instinct and act on their suicidal urge. That is usually a period of minutes to hours. And so for all of those reasons, keeping them safe and alive simply by addressing their safety and the lethal means around them for those moments can be life-saving. Pair those findings with, and this will be the last finding from research I'll share for now, and that is that people who survive a medically serious suicide attempt, the vast majority of them, between 85 and 95%, go on to live out their natural lifespan, meaning they don't ultimately die by suicide. And these are in long-term studies that follow people for years to decades after a medically serious suicide attempt. So again, I know in the clinical world, our views are shaped by the fact that many clinicians treat the sort of most at risk and very ill populations, repeat suicide attempters, and things of that sort. But do realize that among the whole larger population of people who attempt suicide, the vast majority of them survive and do not go on to die by suicide. So that saving a life in those moments can be truly saving a life long term.
So, what are some of the differences that you can say are between people who experience suicidal ideation and those who would actually attempt to complete a suicide? How would those be different?
Well, you're asking the $1,000,000 question, and many scientists are busy at work trying to understand specifically what those differences are and how to predict in real time, so that clinicians can use that information. And right now, one thing I'd like for clinicians to know is that there is no science that shows how to predict short-term risk of attempting or dying by suicide. And so our risk assessment that we're hopefully all well trained in and practice on a regular basis is your best way to determine their level of risk overall clinically, and to use that to inform your care steps. So that's really the main point to be aware of. Now, if we really want to drill down and talk about what does the science show just generally about the difference between what you might call ideators and attempters, people who have suicidal ideation but don't go on to attempt, you can look at factors like impulsivity, history of aggression, history of previous suicide attempts, family history of a loved one, a relative dying by suicide or even attempting suicide. Even having a mental illness in the family can be a risk factor for completed suicide for the person. But again, those don't help so much around an exact prediction science between ideation and attempt.
Now, as mental health providers, clinicians are supposed to be objective and refrain from judgment, and yet the topic of suicide is one that's often judged harshly. What are some perspectives that you could share with us, with our listeners, that can help remove some of this judgment and perhaps increase compassion?
Sure. Well, first of all, I do think it's kind of a mixture for us clinicians in the trenches. There's both kind of compassion fatigue that we can all experience very understandably. But of course, most clinicians are incredibly empathic and compassionate at baseline, and that's why we do this kind of work. But what I would say are probably just reminders that what the science really tells us about the experience of suicidal distress is that people are not using suicide as a for any other reason other than to escape pain generally. Now, there may be some secondary behaviors that develop around that being a especially chronic experience. So there is that layer for sure that clinicians do have to deal with more than what, the science represents something that's really solid, which shows that people have reached a crisis point. That's what drives them to consider suicide and to get closer, if not acting on those suicidal urges and plans and ideations. So that a crisis point has been reached, the pain has become unbearable. And here's where the cognitive constriction comes in that might afford an additional dose of compassion. It's that the person's brain actually changes in that moment temporarily, just like we all do under a state of extreme stress. Our cognition narrows and options become limited. But for the person who's at risk for suicide, that's even more so. And so their options truly have narrowed to this tunnel vision where their way through this problem is now not their usual healthier coping mechanisms, but has honed in on suicide as their means of escape from that pain. So I would try to frame any patient you're seeing in a suicidal moment as coming from there. It will also allow you to explore what those drivers of their distress are and engage with them in such more of a therapeutic alliance producing sort of way so that maybe we can get out of the adversarial dynamic that can develop so often around the topic of suicide, because of course it makes us so anxious. And sometimes patients aren't telling us the full story because they fear being hospitalized. But if we can in a way, take a time out and allow yourself to just go there and ask them, when did the suicidal ideation start? What is the pattern for you? What tends to trigger it? There is an inventory called reasons for living and reasons for dying. And this is a really important tool as part of a therapeutic process called collaborative assessment and management of suicidality, developed and studied by Dave Jobs, an excellent treatment modality, actually. It's abbreviated CAMS. But this reasons for living and dying can be utilized at any point in time and could help guide that conversation that will really show the patient there are ways for them to have more control over their sort of level of distress and how they manage their own suicidal thoughts. This can also involve safety planning. So anyway, those are some thoughts I would have about just really trying to get to that issue of the clinician's role and how can we do the best possible for our patients as well as for ourselves. And all of these things, if we do it and document it well, of course, will mean the best protection as well from a medical legal standpoint.
It seems like there are quite a number of resources that are available if you just know where to look. And I think that's wonderful. So that takes me really to my next question, which is what are some of your thoughts on the black box warnings that are on many antidepressants and correlations with suicidal ideation and or suicidal attempts? What are some thoughts that you could share with us?
Sure. So I will just share my own synthesis of the kind of historical events that happened leading up to and following the black box warning, as well as a few of the studies that happened after the black box warning launched. So just to clarify the black box warning itself, it's a mechanism that the FDA usually reserves for fairly extreme situations with a medication that's been on the market, and that the very next step would probably be to take it off the market. And so it was an interesting choice and a very controversial choice for the FDA to employ that particular mechanism around the topic of suicide risk and antidepressants. Just because, again, usually it's around something that indicates physical toxicity that's one step away from removing from market. And the data set that was used to guide their decision was a data set of a couple thousand patients that showed that for individuals 24 years and younger, there was an increase in suicidal ideation of an additional 2% than placebo. There were very few attempts and no suicide deaths. And most of these increases in suicidal ideation occurred within the first 4 weeks of treatment. So that's just some framing around what the black box warning was and what it came out of. What I will say is my own personal opinion is that there was an unintended consequence of really confusing clinicians, primarily primary care physicians and providers, but others as well, where great fear developed around the use of antidepressants, thinking that it's actually going to cause suicide or increase the risk of suicide. And again, that would be a leap even from the data itself. And so there are studies that showed that depression among younger populations was diagnosed less, was treated less with antidepressants, that there was not substitution in terms of using more psychotherapy and CBT and other modalities in place of antidepressants, and that effect of basically ignoring depression that was in front of primarily primary care clinicians bled up into the older years as well. It was not as dramatic, but nevertheless, it wasn't just contained within the 25 or under 25-year-old patient population. So there was a very ill effect, in essence, of less treatment and identification of depression after the FDA black box warning. There was also another sort of large population study that showed there was an uptick in the rate of suicide attempts that occurred population-wide in the US following the black box warning. That's a bit more speculative because that's clearly not, you can't do a cause and effect study. This is correlation and association only in time. And I guess the last thing I would say is that there are also studies that look at populations county by county and actually found that the counties with the higher rates of antidepressant prescriptions correlated with the counties that had lower rates of suicide and suicide attempts. So again, not, that's not a clear statement, but rather to say there are indications that show that treating depression aggressively and appropriately can also mitigate suicide risk in a prevention effect sort of way. So what we say at the American Foundation for Suicide Prevention is that depression should be addressed, should be identified and addressed in whatever way is best for that patient. And of course, we're advising patients and their families too, advocating for their ability to work with their clinician to not settle for no effect or partial effect, but really to advocate for the fullest optimal treatment effect possible. The one other thing that I would say about the use of medications when it comes to suicide risk is that we now know that to manage suicide risk fully, we can't only treat the primary psychiatric condition or conditions. We actually also have to think about suicide risk as its own entity. And of course, there are some newer medications as like ketamine, as well as older medications like lithium and clozapine that are showing very clear signs of being able to reduce suicide risk for particular conditions. But that is something that I would advise all prescribing clinicians to think about is, of course, first and foremost, manage the primary conditions and now also think about suicide risk. If this is somebody with a mood disorder, then please think about lithium and its very robust literature over 50 different studies that show a 60 to 80% reduction in repeat attempt behavior, as well as reduction in suicide itself.
Thank you so much for sharing all of that great information with us. AFSP website lists two non-pharmacological treatments, CBT-SP and DBT, that have been shown to be effective in particularly effective in preventing suicide. Could you tell us a little bit more about these findings? And could you go into a little bit of background for each of those?
Absolutely. Let's start with dialectical behavior therapy, DBT. So there have been several randomized controlled trials of DBT specifically looking at what happens to suicide risk for the subjects in those studies. And the RCT, of course, means that there is a control group that you're comparing against. And in most cases, the control group is also getting therapy, sometimes an enhanced or expert version of community therapy. So it is not nothing. So it's DBT versus community expert therapy in most cases with the DBT studies. These randomized controlled trials have looked at people with borderline personality disorder who've recently attempted. They have looked at cross-diagnostic populations who've recently attempted. They've also been studied, DBT has been studied in people with substance use disorders, eating disorders, children age 7 to 12, which is a very special type of research to do, prepubescent children with disruptive mood dysregulation disorder, and adolescents with a suicide attempt history. So these are some very diverse and high-risk populations. And what the studies show is that DBT versus community therapy in many of these studies reduces the risk of reattempt. And I'll just point out a landmark RCT published by Marsha Linehan in 2006 in JAMA that found that in 101 women with borderline personality disorder who had recently attempted suicide, who were randomized to either DBT or that community therapy and followed for 2 years, had a 60% reduction in their rate of reattempt. In the adolescent suicide study, which, by the way, did include not just working with the adolescent with DBT therapy, but included family and parental skills and therapeutic engagement. Those studies found that adolescents' reattempt rate was reduced by 70%. So this is why we say there's a body of evidence that shows that DBT has a powerful suicide prevention effect. Now, we could just turn our attention to cognitive behavioral therapy as well, and some of the same themes we're going to see there. But just to summarize perhaps more briefly, the randomized controlled trials of cognitive behavioral therapy, and there have been many, more than a dozen, and in a meta-analysis of those written up by Moutier more recently, I think it was a 2017 meta-analysis, found that CBT does reduce repeat suicide attempts in many cases between 50 and 75%, which is very significant risk reducing effect, but that the CBT that focuses specifically on suicidal ideation, cognitions, and behaviors are the ones that are found to have the most powerful risk reducing effect compared to CBT that's more generally being utilized for the mood or the anxiety symptoms of the patient. So that's a very important thing that is probably true across many different intervention strategies, is that we actually have to go right to and engage with the person's suicidal cognitions and behaviors, which is something, again, that we've been a little bit afraid and hesitant to do in the past in our patient care.
Over here at the Neuroscience Education Institute, we have recently begun to increase awareness for our clinicians on how to handle the loss of a patient to suicide. And we recently had a panel of mental health providers address this very topic at one of our seminars just last year. And we had a poll taken where we asked the audience just prior to this panel discussion how many of them would feel comfortable sharing their experience or talking to a colleague about their experience with losing a patient to suicide. And the audience responded with about 79% initially would be comfortable with talking to a colleague about this. After the panel discussion, that number increased to almost 98% of the people in our audience who claimed that they would feel comfortable actually discussing this situation with a colleague. That being said, what would you say are some things that could encourage mental health providers to speak out to each other? And do you think that perhaps just kind of opening the door to conversation and letting them know that they're not alone, is that something that is considered helpful?
Absolutely. And actually, we view this kind of discussion and collaborative sharing and support for the experience of losing a patient to suicide along the same trajectory of learning how to do suicide prevention as a clinician, because it can be so traumatizing that it can actually inhibit our optimal ability to work with patients at risk for suicide. So this is so important, and I'm so glad that NEI has raised the topic and that it's had some ongoing dialogue. We find the same things to be true, that the history, unfortunately, is one in which our own field had stigmatized the issue of suicide and had such a great degree of misunderstanding, again, perhaps with an exaggerated expectation on the clinician to be able to predict who is at risk and to predict the exact moment, and therefore to be able to prevent suicide 100% of the time. And I would just give a little analogy that in the field of cardiology, cardiologists don't expect themselves to be able to predict who will die of a cardiovascular event and when they will die, but that does nothing to stop them from utilizing all of their prevention strategies, all of their treatments to go after risk factors for mortality due to cardiovascular disease. And we can do the same kind of approach very objectively with regard to preventing suicide in our patients. And I'll just point out that there is one really significant resource related to the topic of losing a patient to suicide. And that is a resource that includes a slide set for teaching residents and other trainees about the experience of loss of a patient to suicide, and also includes a video of expert clinicians like Glenn Gabbard, Jim Lomax, Sid Zissuk, and others talking about the experience. And it will really help to frame both the data that upwards of 50% of practicing psychiatrists will experience the loss of a patient to suicide in their career. Other mental health disciplines are a little bit less percentage of them endorse that experience, but this is very, very common. And so I think many clinicians have kind of suffered in silence over many years and not talked about it because it had produced so much shame and trauma for them, but that doesn't need to be the case.
Yeah. Wow. Absolutely. Well, thank you so much, Dr. Moutier. And I would love to invite our listeners to please check out the AFSP website. There's so much helpful information on the website and just wonderful, wonderful resources. So thank you so much for all that you do. And it was a joy to have you on our show. Thank you.
Thank you, Sabrina. Thank you. The conversation has been stimulating on both sides. So thanks for having me. Bye bye.